So this is the third time I've actually given this lecture at the review course, and as Guy said, your evaluations are really very, very important. Just like the organizing committee and the chairs read every evaluation, I think the speakers also review your comments and take them very seriously and incorporate it to actually improve the lecture and make it more relevant. So I'm going to be speaking about cancer chemotherapy and pharmacology today. I have no financial disclosures, and I will not be discussing any unlabeled uses. However, there are a few other disclosures which I have to make. I am not an expert pharmacologist. There are other people in this room who are better experts. However, this talk is really given solely from the board perspective. It's what you need to know for the boards. And last year, one of the comments in the evaluation was, which was very gratifying, was that every single question on the boards was covered by this lecture as related to this topic. So hopefully it will continue in that same light. So the syllabus is outlined over here. So what I talk first about is the general principles of chemotherapy, speak briefly about the classification and mechanism of action of various drugs, then toxicity essentials, which you really should know, and they may come up in various vignettes, and also particular drug interactions of interest. And then here are odds and ends, which don't really fall under any one of these categories, but are still probably important. So to start with, I mean, the whole goal of using chemotherapy is really with the intent to cure a patient. When children were first diagnosed with cancer and surgery or radiotherapy was the only modality which could be used, most patients relapsed and died. But after we started using chemotherapy, we were able to improve cure rates. And this multimodal therapy now has resulted in an over 80% chance of children being alive 5 years from the diagnosis of cancer. And when you actually look at drug therapy in general, there are very few drug therapies which really aim at cure. One is antibiotics or antivirals, basically drugs to cure infections, and the second are drugs to cure cancer. Most of the other drugs which are actually in place really control symptoms. For example, if you have high blood pressure, an antihypertensive just brings your blood pressure down. It doesn't really cure you of that ailment forever, so you can't really stop it. Similarly, for diabetes and insulin, or if you use antipyretics for fever. And these drugs were really identified by basically in vitro screening of a large number of compounds and exposure to cancer cells. And all they looked at was cell kill kinetics. And so they picked a level of a drug which killed the most number of cells, and then they decided, oh, this is good enough, so now let's try that. And then that resulted in clinical trials being performed. And there are mainly four types of clinical trials: phase 1, phase 2, phase 3, and phase 4, with the latter just being usually post-marketing to look for safety signals or additional efficacy. But the primary first phase clinical trial, or first in human, first in children trial, is usually a phase trial where the prime goal is really to determine toxicity. And so here drugs are usually escalated till they find a dose which has a particular, which does not cause toxicity or causes greater than 33% toxicity in most cases. There are some trials where they may set the bar a little higher. The standard phase 1 design is usually a 3+3 design, and that assumes that the majority of patients who are going to be treated would have less than or equal to 33% toxicity. So if one in the first 3 patients has a toxicity which is unacceptable or what is dose limiting, then it's expanded to another 3 patients. And then as long as no other patient experiences a toxicity, the dose can be escalated. If 2 patients out of those 6 or then experience a toxicity, then the dose level is usually dropped. Once you actually know which drug is the maximum what dose of drug is the maximum tolerated dose, then based on further preclinical data, it's tested in various cancers. And it's usually a set number of patients with a particular type of disease. And over here, you're looking for efficacy. And as evidenced by a response rate. Now, that has changed, and some people have begun to look at clinical benefit rate and then progression-free survival. But typically, you usually want to have a response rate of about 20 to 30% with a particular drug to consider it active to move it forward. And then the true gold standard is the phase 3 clinical trial, where you actually perform a randomized clinical trial with the standard versus the new therapy and incorporate it. And then whichever one comes out at the end as the winner just becomes standard therapy. So, going back. So during phase 1 clinical trials, you also try to learn more about the drug and the way the body handles the drug. And that's usually to study the pharmacokinetics. Sometimes you're able to also study the pharmacodynamics of the particular drug. So one of the prime principles in curing therapy is really what we learned from antimicrobial therapy, that by using multiple drugs with different mechanisms of action, the chances are that you're able to effectively eradicate the disease. And therefore, one of the prime principles in curative chemotherapy is to use multi-agent chemotherapy. And so you usually pick drugs which do not have a similar mechanism of action. For example, if you use VAC chemotherapy, which is used in the treatment of rhabdomyosarcoma, it's the combination of vincristine, which is microtubule inhibitor, and actinomycin D, which is an antibiotic and intercalating agent, and then cyclophosphamide, which is an alkylating agent. You almost never see two topoisomerases, for example, combined together, like using doxorubicin and etoposide, because they have a similar mechanism of action. Then there are some drugs where there is no cross-reactivity with cross-resistance at all, like high dose, like methotrexate, and that's what's employed in osteosarcoma, where you usually start off patients with cisplatin and doxorubicin, and then while they're recovering or they haven't recovered completely, you give them high-dose methotrexate so that there is no chance of overlapping resistance occurring during that time. The next principle is really, when is chemotherapy most effective? And the teaching is that chemotherapy is probably most effective in the adjuvant setting, or when there is microscopic residual disease, when the majority of tumor burden has been addressed in a different way, and that's usually by surgical resection of solid tumors. And that is the premise of the Goldie-Coleman hypothesis, which basically suggests that your best chance of curing a particular tumor is if there's no drug resistance and you use as many active agents at the highest possible dose. And that takes into consideration that number one is that in order to be cured, you basically should have cells which are sensitive to chemotherapy and no drug resistant cells. And usually most drug resistance is caused by genetic events. And there are different ways of actually intensifying chemotherapy and maintaining dose intensity, and one is to keep up with the frequency of chemotherapy. And our supportive care has really helped us do this by giving transfusions, by having myeloid growth factor support. We prevent extraordinary delays of chemotherapy and are able to actually give chemotherapy on time. We can increase the dose intensity therapy by increasing the total dose of chemotherapy. And this is based on preclinical data where you actually, if you increase the dose of chemotherapy by 2 or 3-fold, you can actually increase cell kill by about 10 to 15-fold. And so the effect is much more than what you actually do. And the other way is to actually interval compress chemotherapy, and let's give it more closely. And most of our information on dose intensity and its efficacy in the management of cancer really comes from breast cancer trials. But we have our own experience in pediatric oncology, first starting with leukemia trials, both in ALL and AML. If there are individuals in the room who knew that, doctor therapy, which was basically, before the body had a chance to recover after the first cycle of chemotherapy, they gave a second cycle of the same chemotherapy, and then with growth factor support, supported patients right through the prolonged recovery period, and that sort of improved outcomes. Similarly, recently with Ewing sarcoma, interval compressed chemotherapy was able to increase dose intensity by 33%, which then resulted in an 11-point improvement in EFS of patients with localized Ewing sarcoma, and is now considered the standard of care for their treatment in North America. So the other important thing to know is really the cell cycle and the various phases of cell cycle and where the different drugs act. So most of you are familiar that G0 is the quiescent or resting phase when the cells have actually left the cell cycle. It's during that phase where alkylating agents are usually active. Then after the G0 phase, the cells go into the G1 phase where there is actually biosynthesis. The cells grow in size, getting ready for the synthetic phase, or the S phase, where the majority of DNA replication takes place. And then there is another phase of growth after DNA replication happens, and that's the G2 phase, again where there's a lot of protein synthesis preparing the cell to actually get ready for mitosis, and which is called the M phase, before cell division. And so based on these cell cycles, anti-metabolites, because they're incorporated into DNA during replication, almost act exclusively during the S phase. And so if you get a question related to that and you know the mechanism of the drug, that should be the answer. Similarly, the mitotic spindles occur during chromosomal separation during the mitotic phase, and that's where vincristine, the Vinca alkaloids, and other spindle inhibitors like the taxanes actually work. Hormones are also non-cell cycle specific, and this is basically glucocorticoids, which we use a lot in the treatment of leukemia. So there are many mechanisms of drug resistance. Most of them are genetic. There is you could have mutations in receptors on the surface of cells, or a decrease in the amount of a receptor, and therefore there's decreased uptake of this drug into the cell, thereby causing resistance. And the classic example of that are corticosteroids and methotrexate. You can have decreased intracellular drug activation, and this again could be an effect of a drug interaction where the particular drug inside the cell won't be able to work. You can have increased catabolism of the drug, as for example, increased glutathione transferase with cyclophosphamide. You can have altered affinity, and again, this is, with methotrexate, it's related to the amount of dihydrofolate reductase within the cell. And then you could also have a difference in the competitive substrate. And that's typical with cytarabine. And so if you actually give asparaginase, you're actually depleting deoxycytidine within the cells, and therefore decreasing the ability of asparagine to actually work. So you could also have increased resistance by MDR expression, which increases, the P glycoprotein pump on the surface membrane, which acts as an active efflux mechanism. We spoke about glutathione S transferase, similar to cyclophosphamide. And then again, similarly with if there is less topoisomerase 2 activity, topoisomerase inhibitors are not really going to work. You could also have enzyme upregulation of certain enzymes which actually repair cells rapidly, allowing them to be resistant. And the classic example of that is MGMT expression and temozolomide resistance. And then increased expression of anti-apoptotic proteins like BCL2 can also contribute to drug resistance. So one of the other areas which is frequent source of questions on the board is related to central nervous system pharmacology. And it's because this, of the blood-brain barrier, the central nervous system is a particular place, and normal metabolism as experienced elsewhere in the body is a little different. And why is this relevant? Of course, because, the second most common type of cancer in children are brain tumors. We know that the central nervous system is a sanctuary site in leukemia, and less frequently solid tumors can metastasize to the central nervous system. There are a lot of determinants of CNS penetration, and the specific drug properties are lipophilicity, molecular size, decrease in ionization, and free plasma concentration, including cerebral blood flow. So there are various strategies to enhance central nervous system penetration, and that's by, number one is by using very high doses of chemotherapy. The classic examples are methotrexate and cytarabine. In fact, as many of you all know, infant leukemia has a very high incidence of having CNS disease, and in a couple of decades ago, they used to use 33.5 grams of high-dose methotrexate to give these infants with an attempt that it would penetrate into the central nervous system and cure them of their CNS leukemia. Then there are other drugs which you actually have similar levels in the plasma as in the CSF, and those are the nitrosoureas, thiatepa, and the camptothecins. And that's why you will see that those drugs are predominantly used in the treatment of brain tumors. So that's CCNU and BCNU, or carmustine and lomustine, and then the camptothecins, irinotecan and topotecan. There are some strategies, particularly in the treatment of brain tumors, where drugs are administered together with mannitol so that they can disrupt the blood-brain barrier and hopefully increase penetration. And then, of course, the next principle is to give drug which intrathecally, which is what we commonly use in leukemia, and probably contributed to the biggest improvement in survival in leukemia. What is really important over here is that you can only instill an active drug into the intrathecal space. So if you're actually going to think about a drug which requires to go through the liver, to be metabolized, to be activated, then that drug should not be used as an intrathecal drug. So you might get a question on your board saying you're designing a new intrathecal therapy and you want to select a camptothecin, for example, and they'll say, which one would you pick? Would it be topotecan or irinotecan? The answer should be topotecan rather than irinotecan, because irinotecan gets activated to SN38 in the liver, which is the most active form of the drug, and you don't want to use a prodrug to be instilled into the CNS. So the other important thing is age, and this is really work which was done by Dr. Poplak when he was at the NCI and his group, really looking at cerebrospinal fluid volumes. And what he found was that after 3 years of age, the amount of cerebrospinal fluid equated what you would see in an adult, and that formed the basis of dosing of therapy. And traditionally, these were the doses picked for methotrexate. If you're less than 1 year of age, the dose administered intrathecally was 6 milligrams and 15 milligrams for cytarabine. Between 1 and 2 years of age, 8 milligrams for methotrexate and 30 milligrams for cytarabine. Between 2 and 3 years of age, 10 milligrams of methotrexate and 50 milligrams of cytarabine. And over the age of 3, the standard dose is 12 milligrams of methotrexate and 70 milligrams of cytarabine. Now, many of you maybe use the more modern protocols are using even higher doses of methotrexate at 15, but that's not really based on pharmacological data. That was based on escalation, which was done by the French non-Hodgkin lymphoma studies. It was found to be tolerable and therefore adopted across other therapies. So moving on to the classification and mechanism of action of chemotherapy agents. So they are broadly classified as following: alkylating agents, antimetabolites, antibiotics, plant products, there are miscellaneous drugs, you have kinase inhibitors, other small molecular targeted agents, and monoclonal antibodies. And this is one figure which is in the slide and is really adapted from one of Dr. Adamson's schematics. And I think this also may be present in every edition of PISO and POPLAC, but it's very useful to sort of understand where various drugs work. And so to spend some time looking over it, that there are drugs which really work at the level of DNA. Those are typically the anti-metabolites, except for 5-fluorouracil, which really works at RNA. Then there are drugs which work at the protein level, and typical of that is asparaginase, which inhibits protein synthesis. Then you have other intercalating agents in with DNA, and which are predominantly the antibiotics, and then the alkylating agents, which basically also form cross-linking and alkylate and alkyl groups to basically cause DNA damage. So the alkylating agents are further classified into nitrogen mustard, and they work by alkylation and cross-linking. Examples of them are mechlorethamine, cyclophosphamide, ifosfamide, and melphalan. Mechlorethamine was actually the first drug used, and was used in the treatment of Hodgkin's lymphoma, and we don't use it anymore because we actually have better drugs. The big challenge with mechlorethamine was not just its myelosuppression, but also its severe gastrointestinal toxicity. Nitrosoureas also work by alkylating and cross-linking, but also by carbamylation. And these examples of these are lomustine and carmustine. Carmustine is also called BCNU and lomustine is CCNU. The way I remember it is that it's the opposite. So if it starts with B, the true name starts with a C. So BCNU becomes carmustine. Anyway, and then there are platinum compounds which work by as heavy metals and platination and are similar to the other alkylating agents by causing cross-linking. And typical examples of that are cisplatin, carboplatin, and oxaliplatin. And then you have alkylating sulfones like busulfan, which is primarily used in conditioning regimens for bone marrow transplant. And again, that's an alkylator and a cross-linker. And then methylating agents, which are dacarbazine, procarbazine, and temozolomide, which, as the name suggests, work by methylation and free radical formation. The toxicity of this entire group is pretty similar. They all cause nausea, vomiting, alopecia, and myelosuppression. Cyclophosphamide, ifosfamide, and melphalan can cause hemorrhagic cystitis. They all uniformly cause infertility, and they can cause secondary leukemia. This leukemia is a little different, and we'll allude to this a little later, from what is caused by topo-2 isomerases, and they typically happen a little later. And usually, associate with myelodysplasia, monosome 7, and deletion of 5q. With ifosfamide, you can also have Fanconi syndrome and neurotoxicity. And with busulfan, you have pulmonary toxicity. Moving on to the anti-metabolites, you have the folate analogs, and they interfere with folate metabolism. And the classic examples of that are methotrexate, trimethotrexate, and pemetrexed. The pyrimidine analogs, which are incorporated into DNA or RNA, they can inhibit DNA polymerase and inhibit ribonucleotide reductase, as in the case of hydroxyurea. Examples are cytarabine, gemcitabine, and fluorouracil. And then there are the purine analogs, which are also incorporated into DNA and RNA. They block purine synthesis and interconversion, inhibit DNA polymerase, and ribonucleotide reductase. Examples are mercaptopurine, thioguanine, fludarabine, clofarabine, cladribine, and nilarabine, which is also called ARA-G. Their main toxicity is myelosuppression, and in the case of thioguanine, it can also cause a hepatopathy or a sinusoidal obstruction syndrome like picture. You can get a rash with clofarabine, and nilarabine can cause somnolence and other forms of neurotoxicity, which are pretty specific. The antibiotics work as intercalating agents. They can also cause DNA strand breaks and can prevent DNA ligation through their topoisomerase 2 inhibitory activity, and also can exert cell damage by free radical formation. Classic examples are dactinomycin, doxorubicin, daunorubicin, idarubicin, mitoxantrone, and bleomycin. The toxicity is nausea and vomiting, mucositis with doxorubicin, daunorubicin, idarubicin, and mitoxantrone, cardiac toxicity. They're all vesicants and can cause pretty bad burns if they leak out of a vein, and they can cause secondary leukemia, and this leukemia is usually 11q23 leukemia, and this can occur any time after exposure. So you can actually have a patient on an active therapy for a solid tumor cancer being treated with these agents, and then also get a leukemia. But these leukemias tend to occur usually in the first 2 to 5 years following exposure. As you can see, bleomycin is also associated with pulmonary toxicity and anaphylaxis. So in general, if you get a question about pulmonary toxicity on your boards, I mean, just pick the drug which starts with a B. So usually it's involved, and actually I think I first said this about 3 review courses aboard, and I think that people have taken that and run with, and I should have patented it because I see it used at a lot of late effect talks right now. So moving on to plant products, vinca alkaloids, like we spoke earlier, are mitotic inhibitors, and they block microtubule polymerization. The main drugs which we usually use in this group are vincristine, vinblastine, and vinorelbine. Their toxicity is mainly neurotoxicity, SIADH. Thrombocytosis is not really a toxicity, but it's noted with vincristine. They can all cause pretty significant extravasation burns, and in the case of vinblastine and vinorelbine, they are myelosuppressive, and that's a key difference between vincristine and the other 2 vinca alkaloids. The taxanes are also microtubule inhibitors, and they block microtubule depolymerization. The examples are paclitaxel and docetaxel. We don't use them much in pediatric oncology, though they're being used in sarcomas more at this time. And their toxicity here is that since these are plant products, I mean, they can actually cause pretty significant allergic reactions, and so very often pre-medication is recommended. They can also cause skin toxicity, hand-foot syndrome, and also cause neurotoxicity. The other topoisomerase inhibitors, and these are excluding the antibiotics, the epipedophylotoxins. Sorry, this slide is actually missing in your handout. I apologize for that, but this is the only slide which is missing. The topo-2 isomerase inhibitors, etoposide, VP16, which is commonly used, and tenopicide or VM26, which is not being used as often but works in a similar mechanism, and the camptothecins, which are topoisomerase 1 inhibitors, which are topotecan and irinotecan. Their main toxicity is myelosuppression, hypersensitivity reaction, and 11q23 leukemia. What is important to note that it's actually rare to have a true allergy to etoposide, and most of the reactions which we actually see is related to the carrier in which etoposide is supplied with, and therefore the variant etopophos usually prevents most of those reactions. And then in the case of irinotecan, depending on the schedule and the dose, myelosuppression and gastrointestinal toxicity are predominant. So moving on to other drugs which are really not classified into broad chemotherapy agents, and one of the most common ones is asparaginase, or PEG asparagase, or ervinase. These drugs, this drug acts by depleting the circulating pool of asparagine, and sensitive cells really cannot upregulate asparagine synthase, which is required for the synthesis of the amino acid, and therefore it's not available for protein synthesis. By pegylating asparaginase, it decreases the immunogenicity, since this is a bacterial product and you can have antibodies, and it also increases the half-life of drug, and it decreases the clearance of dexamethasone, so it actually potentiates the toxicity of glucocorticoids. So the main toxicity again is allergic reaction. I'm sure most of you have seen patients who've actually had an allergic reaction. They can also have significant coagulopathy, which is related to the protein synthesis inhibitory effect. And you can have both thrombosis and bleeding, though thrombosis seems to be a much bigger problem than compared to bleeding. Hyperglycemia, again, by inhibiting insulin production. Pancreatitis, again, by the enzymatic activity in the pancreas. It can also cause hepatotoxicity and encephalopathy. Corticosteroids really act by causing receptor-mediated lympholysis. Basically, these steroids go and activate glucocorticoid receptors, which then get translocated into the nucleus, where they dimerize and bind to DNA, and then affect various downstream pathways, which results in apoptosis of the cells. The other important point to note is that the drug concentration in the CSF is the same as the plasma. So steroids are generally very good, and that's one of the other reasons why steroids are used in the treatment of leukemia, and one of the reasons why dexamethasone is superior to prednisone is because of the CNS penetration. So the toxicity, of course, is very familiar to most of you. It's increased appetite, centripetal obesity, immune suppression, myopathy, osteoporosis, avascular necrosis, gastritis, pancreatitis, hypertension, hyperglycemia, growth failure, impaired wound healing, and cataracts. Retinoids are other agents, which are the main area which we use in the treatment of APML and in the treatment of neuroblastoma. The two forms are all-trans retinoic acid, which is used in APML, and 13-cis-retinoic acid, which is used in the treatment of retinoblastoma. And then, of course, we use arsenic now, which acts by causing apoptosis and degradation of the PML-RAR alpha receptor, and continues to be investigated in APML. The main toxicity is teratogenicity. That's why you've got to fill out that I pledge form. It can also cause retinoic acid syndrome, which is usually manifested with cardiac and pleural effusions, fever, respiratory distress. They can also cause cheilitis, xerosis, conjunctivitis. Arthralgias, joint pains, are fairly common in patients, particularly with cis-retinoic acid, and they both can cause pseudotumor cerebri. Arsenic can also cause hepatotoxicity, dermatitis, convulsions, and can prolong your QT interval, which can predispose you to arrhythmias. So there's a large number of new small molecules and kinase inhibitors, and we probably don't have time to go into every one of them. But what I've done is provided a list of you of at least the familiar agents. All the agents which are actually listed here have been approved. None of these are non-approved, but as you know, most of them are not been approved in pediatrics for use, and we are still studying them. And they target various kinases, which basically usually have a tyrosine, serine, or threonine moiety. And you can actually develop resistance to these particular agents by having very selective mutations in their binding domains. There are also a list of monoclonal antibodies which target several agents, and you could actually get a question on these based on an epitope which is present on a cell, and they'd ask you which is the drug which you would probably pick. And so if you actually have CD33 over there, the answer is going to be gemtuzumab, ozogamicin. And now you have the newer drugs which have all been recently approved, the bispecific antibody blinatumomab with CD19 and CD3, the checkpoint inhibitors, the anti-PD-1 drugs, nivolumab and pembrolizumab, which have been approved, and then atezolizumab, which is an anti-PD-L1 drug, and more recently olaratumab, which is a monoclonal antibody against PDGFR, which is approved for the treatment of advanced sarcomas. So here is a little table to just basically look at an acute toxicity and what you do to mitigate toxicity. So many of your vignettes which you would get in your tests will probably ask you, what's an antidote, or how do you manage this? And some of them speak for themselves and sound really routine. The other ones are pretty specific. So for allergic reactions, we would use corticosteroids, diphenhydramine, epinephrine, other antihistamines. Nausea and vomiting, there is a wide variety of antiemetics which are available. Myelosuppression, of course, we can't give most of our intensive chemotherapy without growth factors. We have a wide array of antimicrobials for all the infections which our patients are exposed to. For tumor lysis syndrome, which is a complication of induction therapy in leukemia, Burkitt's lymphoma, and rarely in solid tumors, we can still use allopurinol and rasburicase to manage uric acid, which is hyperuricemia, which is a byproduct. Hemorrhagic cystitis has virtually become a thing of the past with the use of Mesner. What is really important to know is that Mesner is administered first in the active form, but immediately is inactivated in the blood by getting oxidized, and then when it's transported across the renal tubule, it gets reduced again into its active form, and there it binds to acrolein and prevents hemorrhagic cystitis. And the importance of that is that because it's inactive when it's in the circulation, there's no tumor protective effect of Mesner. For cardiac toxicity, we also use dexazoxane. Dexazoxane, by the way, is also approved for the treatment of an extravasation burn with anthracyclines, and this may also be on your boards. And usually the dose is 1,000 milligrams per meter squared IV for 2 days, and then 500 milligrams per meter squared on the third day. That's the approved indication for extravasation burn, which is very different from the other management of other extravasation burns, which is mainly local therapy where people have injected DMSO and also injected sodium thiosulfite to mitigate some of the toxicities. We mitigate nephrotoxicity with cisplatin by mannitol diuresis. For methotrexate toxicity, we have leucovorin rescue, and more recently we have glucopidase or vorexase. And the use of dextromethorphan for CNS toxicity is still very controversial, but people use it. Neurotoxicity for ifosfamide is managed with methylene blue, and dexamethasone is not truly a treatment for Atra syndrome or retinoic acid, but prophylaxis with dexamethasone may decrease the incidence of retinoic acid syndrome. When you look at chronic toxicities, and the drugs responsible, again, we've covered many of them, but cardiac toxicities, the anthracyclines automatically, pulmonary toxicities are drugs starting with the letter B. Infertility, alkylating agents, obviously osteonecrosis, corticosteroids are the biggest culprit. Secondary leukemias, it's important to pay attention to this, that depending on the type of agent, the type of leukemia, therapeutic induced leukemia which you get can be different, and I think this is also a favorite question on the boards. Cisplatin can cause hearing loss, which is sensory neural hearing loss, which is irreversible, and then nephrotoxicity is there's this typo over there, I'm sorry, is a toxicity of cisplatin and ifosfamide. What is important to know is that if you're previously exposed to cisplatin, then exposure to ifosfamide can increase nephrotoxicity. And usually using cisplatin and ifosfamide together is not as bad as using ifosfamide after you use cisplatin. And then, of course, radiation recall injury is typical of anthracycles and actinomycin D, and that is the reason why they are held during radiation. And this is of particular importance for patients with sarcomas, where we frequently use chemotherapy together with radiation therapy. So going into the individual drugs where we can spend a little more time, starting with the oxazophosphorins, cyclophosphamide and ifosfamide are the most common. They are both prodrugs. They are hydroxylized in the liver, and then they are metabolized ultimately to phosphamide and iphosphoramide, mustard and acrolein, and acrolein is what causes hemorrhagic cystitis. So they are detoxified by various mechanisms, but one of the mechanisms is dechloroethylation. It's important to know that only 10% of the cyclophosphamide metabolism is through dechloroethylation, while for ifosfamide, more than 50% of it goes through this mechanism, which results in higher levels of chloroacetaldehyde, which is believed to cause neurotoxicity. And that's why you see neurotoxicity with ifosfamide and not with cyclophosphamide. Busulfan can also can block the activation of cyclophosphamide, and purists would recommend that you wait at least 24 hours after a dose of busulfan to actually give cyclophosphamide. I think most transplanters sort of ignore that. Busulfan, the important thing to know is that the pharmacokinetics is very variable, especially with the oral drug, and it is age dependent. Younger children clear busulfan faster, and basically by using the intravenous form, you decrease interpatient variability. Levels of greater than, AUCs of greater than 1200 basically are associated with hepatotoxicity and veno-occlusive disease, and those between 800 and 1200 are considered optimal for engraftment. This drug also has good CSF penetration, and as I mentioned, high doses are used in the treatment of bone marrow transplant conditioning regimens. Moving to platinum compounds, again, the important thing over here for the different platinum compounds is that they have different dose-limiting toxicities, and this is important to know, and you could get a question on it. Cisplatin, the DLTs, are nephrotoxicity and sensory neural hearing loss. For carboplatin, it is actually myelosuppression and not renal toxicity, but you do need good renal function to prevent severe myelotoxicity. And for oxaliplatin, neurotoxicity is the dose-limiting toxicity. Patients with who get oxaliplatin have an incidence of laryngotracheal dysesthesia. So it's actually a feeling, a subjective feeling that you actually can't breathe, and they like gasp for air, and it's actually precipitated by cold. So you tell them to avoid drinking cold things or going out in the cold air, or touching cold things, because that can precipitate this scary side effect. And as I said, carboplatin clearance is highly correlated with GFR. And so you use the Calvert formula, which many of you are familiar with, to pick your AUC of what you want to dose, very importantly. And so usually what is done in newly diagnosed patients, like patients with germ cell tumors, is that we aim for an AUC of 6 to 8 milligram times minute per ml. And in salvage regimens, like when you're using ICE chemotherapy, which is ifosfamide, carboplatin, and etoposide, you usually aim for a higher AUC, which is closer to 10. But what you should know is that the higher AUC will result in more severe myelotoxicity, particularly thrombocytopenia. So moving on to the thiopurines, the ones which we use every day are mercaptopurine and thioguanine. They are both prodrugs. Thioguanine is actually much more potent than mercaptopurine because it's more readily available. 6-MP metabolism, it goes through 3 steps to actually get into to become TGMP. So you get, it's first converted into thioinosine monophosphate, and then it goes to thioxanthocene monophosphate, and then finally into thioguanosine monophosphate, which then gets phosphorated into TGTP, which then gets incorporated into DNA and then and prevents DNA synthesis. So so thiopurine methyltransferase, TPMT, is an important drug in the elimination of thiopurines. And why is it important is that this enzyme, there are various polymorphisms in the population, and the majority of patients will actually, will have the wild type TPMT and will just be fine. There's a significant number of patients, about 20 to 25%, who would be heterozygotes, where they could have some effect on their blood counts with standard exposures to 6-MP or 6-TG. And then there's a small homozygous group, which is about 5% or less than 5% of patients who can be homozygous and have very severe toxicity related. So the ones that more than 95% of the homozygous variants are those with the STAR3A, STAR3C, and STAR2 polymorphisms. They account for more than 95% of the homozygous TPMT deficient patients. And those patients can only tolerate maybe about 5 to 10% of 6-MP or 6-TG. And so if you actually have that information in that group of patients, you would adjust the dosing right up front, because you would lose all your dose intensity if they had the toxicity. For heterozygotes, you do not adjust based on the genetic polymorphisms detected. You rather would use the absolute neutrophil count and platelet count to determine your dosing. So you would start them at a regular dose and then dose reduce them depending on your counts till you find a sweet spot which they could actually tolerate. So the other thing, now this is something which is a little archaic, but they love asking this on the boards. Don't ask me why, but it's important to know that one of the other end products of thiopurine metabolism, 6-MP metabolism, is thiuric acid, similar for 6-TG. But 6-MP, this is catalyzed by xanthine oxidase. And as you know, allopurinol is an inhibitor of xanthine oxidase. And therefore, if you use allopurinol together with 6-MP, then you can have increased myelotoxicity with the drug. So therefore, the recommendations are, if you use them together, that you dose reduce 6-MP 75%, or in other words, administer only 25% of what you would actually give them. Now, we almost never use 6-MP and allopurinol together, but just to illustrate this point, I think one of the questions I created is with a regimen called POMP, which was used 40 years ago, I think. But anyway, now this doesn't happen with 6-TG because 6-TG is catabolized to thiuric acid by aldehyde oxidase via 8-hydroxylation of thioguanine, and therefore you don't have to worry about it with 6-TG. So temozolomide is also a prodrug. It is metabolized to MTIC in solution at a physiological pH, and this is the active component which has its anti-cancer activity. What is important to know with myelosuppression that you have a prolonged nadir over here, particularly with platelets, and it's longer than most other drugs, which is 10 to 14 days. With temozolomide, it's 21 days. And so O6-alkyl guanine alkyl transferase, that's the generic name, but in this particular case, it's MGMT. It removes the methyl adduct from O6 position of guanine, allowing DNA to repair itself and thereby render cancer cells resistant to temozolomide. And they've actually done studies in adults with patients with glioblastoma multiforme, where they actually have tumors which have high expression of MGMT, that those patients do less well when they are treated with temozolomide compared to those who don't have high levels of MGMT. So moving on to methotrexate. So methotrexate is probably the drug which is used in the most number of cancers. I think if you had to pick a drug, a single chemotherapy agent in pediatric oncology which is used most often, it'll be methotrexate. Probably check with your pharmacist. But it basically is an inhibitor of dihydrofolate reductase and prevents the conversion of folate to tetrahydrofolate. And if you remember from biochemistry, tetrahydrofolate is what donates the carbon in purine synthesis. And so if the carbon is not transferred, you can't synthesize your purines, and therefore it prevents DNA replication and therefore cell division. So when the tetrahydrofolate pools are depleted. So in addition, there is another mechanism, and that is that within the cell, methotrexate is polyglutamated. And this accumulates within the cell and has no way of exiting outside the cell, and therefore that leads to apoptosis of the cell. And the polyglutamated compound can also continue to inhibit DHFR, furthering the toxicity. And this is what is actually utilized in the so-called Capezi-1 regimen, where methotrexate is administered 24 hours after, so asparaginase is administered 24 hours after methotrexate, and it rescues you from the toxicity of methotrexate, and that's presumably by depleting your asparagine pool and glutamine, and therefore polyglutamation cannot actually take place. On the other hand, if you give asparaginase before you give methotrexate, then you don't have because your asparagine pool is already depleted, you don't have the opportunity for polyglutamation, and therefore methotrexate is also less active and therefore is contraindicated to give asparaginase before methotrexate. So you should always give asparaginase after methotrexate. And you know, I've often wondered, when Capezi designed this regimen, it was with L-asparaginase, and we've moved to PEG asparaginase, and we still keep calling it Capezi-1 methotrexate. And given that peg asparaginase is long-acting, I don't know what that really does to the once in 10-day dosing of methotrexate. So probably the effect we are seeing is just the general anti-leukemic effect, rather than with the intent Capizzi wanted to actually administer it. And who knows? I mean, I may be treading in unfamiliar waters here, but that could be one of the reasons why there was a difference between high-dose methotrexate and Capizzi methotrexate in the treatment of leukemia. So moving on to leucovorin rescue, higher doses of leucovorin, it's really hard to use higher doses of methotrexate without leucovorin because of the severe toxicity it can cause. And so any dose which is 500 milligrams per meter squared or higher must be accompanied with leucovorin rescue. Otherwise, you will have toxicity from methotrexate. So the important thing is that it does not require DHFR, and it can be metabolized directly to tetrahydrofolate. So it basically replenishes the folate pool required for purine synthesis. The other important thing is that cancer cells lack a transporter for leucovorin. So therefore, cancer cells cannot be rescued by leucovorin. It's usually initiated a minimum of 12 to 20 hours after the end of a methotrexate infusion. Usually in osteosarcoma patients, we start at 20 hours after the end of a methotrexate infusion. Some of the leukemia protocols started earlier. We usually continue leucovorin until serum levels are less than 0.1 micromolar. But in some cases, it's stopped a little earlier, where you actually want to have a little bit of methotrexate toxicity. And this curve is very familiar to all of you. And I tell all my fellows, never assume that you can look at a level and say you know what to do with leucovorin. Pull this chart out and look at it every single time, and then really plot where your patient is. And that's really important, because I don't know, in our practice, I mean, even though we've been using methotrexate for years and years and years, every year we have patients who have severe methotrexate toxicity, and many times it's because some safety factor was overlooked, and it's not idiosyncratic. So coming to those factors for methotrexate toxicity, it's really important to know that salicylates, NSAIDs, penicillins, probenicids, ciprofloxacin is missing from this list, sulfasoxazole, iodinated radiographic contrast, and proton pump inhibitors, so lansoprazole, omeprazole, pantoprazole, all can delay methotrexate infusion, and this is very important. So if you want to use gastritis prophylaxis during methotrexate, it has to be ranitidine, famotidine, or cimetidine. Never use one of these new proton inhibitors. And this is important, and if to know, because people feel very comfortable in prescribing all these different drugs, and if they don't know the context which this happens, then it can result in pretty significant toxicity. Also, it's not a good idea to have any radiographic studies in patients receiving chemotherapy because of this particular condition. So we do have an antidote now called glucopidase, which actually hydrolyzes methotrexate down to damper, and this damper is excreted to the bile, and you can't rely on the kidneys to excrete. And so therefore, when you have no renal function and you have very high levels of methotrexate, this is an alternative which is actually being used and readily available. It's indicated when the serum creatinine is greater than 2 times baseline, or a 24-hour level of greater than 50 micromolar, a 48-hour level of greater than 5, or a 42-hour level of greater than 10 micromolar, and serum creatinine more than 1.5 times baseline. You shouldn't, and since leucovorin is a competing substrate, you shouldn't use leucovorin 2 hours before and 2 hours after administering carboxypeptidase. And if any of you have used carboxypeptidase, the methotrexate levels drop to nothing very, very rapidly. So moving on to irinotecan, the important thing is irinotecan is also a prodrug. It's converted in the liver and the GI tract to SN38. which is 100 to 1,000 times more potent than irinotecan itself. The dose-limiting toxicities, as we said earlier, are myelosuppression and diarrhea. So SN38 is conjugated in the liver to SN38 glucuronide, and that is by the uridine diphosphate glucuronyl transferase 1A1 enzyme. And now there's a big part of the population which actually has UGT1A1 deficiency, and those are patients with Jabez and Crigler-Najjar, and they can inhibit that. And then there are drugs which can also inhibit UGT1A1, such as sorafenib and valproate, and so therefore those can increase toxicity. So once SN38G is excreted into the bile, into the gut, glucuronide gets cleaved by intestinal bacteria and can get reabsorbed. And this is what causes the prolonged diarrhea noticed with irinotecan. So one way to mitigate this is actually to give antibiotics like cefixime or cefpodoxime. And what that does is it rids the normal flora in your gut, and therefore the glucuronide cannot be cleaved off SN38G, and therefore it remains inactive and prevents the reabsorption of the active compound in, thereby mitigating diarrhea, and you're able to actually escalate doses of irinotecan because of that, without having a gastrointestinal toxicity be dose limiting. So retinoic acid, again, is used in APML and high-risk neuroblastoma. Important thing to remember is that the drug is teratogenic. Retinoic acid syndrome causes weight gain, respiratory distress, serous effusions, which can be serious too, and cardiac and renal toxicity. Prophylaxis is with dexamethasone, and both of them can cause pseudotumor cerebri. I threw in rituximab for particular reasons. Again, these are questions. This is the first FDA-approved monoclonal antibody. It's widely used in the treatment of non-Hodgkin's lymphoma, particularly in adults. The important thing to remember is that by suppression of these B cells caused by rituximab, you can reactivate hepatitis B infection, which can lead to fulminant hepatitis, liver failure, and death. So it shouldn't really be used in patients with a history of infectious hepatitis. Similarly, gemtuzumab ozogamicin is a monoclonal antibody against CD33, which is expressed in AML cells. It is linked to a cell toxin called killichomycin. It's this killichomycin bit which can cause hepatotoxicity, which is noted independent of bone marrow transplant, and it was withdrawn because of some increased mortality noted in phase 4 studies in adults. Another random drug is interferon alpha. You may get a question on this. It's not really in the syllabus, but I've noted questions come up on the board, so I threw this in. It is the first therapeutic protein used for anti-cancer therapy, which was created based on recombinant DNA technology. It's approved for the treatment of hairy cell leukemia. Its use in CML is vanishing, as is in multiple myeloma and other drugs, and we use it mainly in vascular anomalies and giant cell tumors now, with very limited use in other neoplastic diseases. It binds to specific plasma membrane receptors and simulates various genes. It has an anti-angiogenic effect. It activates the immune system and also increases the immunogenicity of tumor cells by direct gene stimulation. So the questions asked are usually related to the toxicity of this drug. It's a very difficult drug to tolerate. It causes chills, rigor, fevers, malaise, myalgias, mild neutropenia, fatigue, anorexia, weight loss, transaminitis, and depression, proteinuria, like any protein would do, nephrotic syndrome, and acute renal failure. And this was also one of the reasons why, when we did a randomized trial in osteosarcoma, a lot of patients did not continue interferon because of its toxicity, and very similarly in the treatment of melanoma, where it was used in the ECOG trials, there was much poorer compliance, and now obviously we have better drugs to use. In infants, it's noted to cause this specific toxicity called spastic diplegia. That's why it's not recommended to be used in children less than 1 year of age. And it can also cause hypothyroidism, and this hypothyroidism is because of a cross-reactive antibody. So it's an autoimmune thyroiditis. Quickly, a few lines about rasburicase. It's recombinant urate oxidase. It converts uric acid to water-soluble allantoin. Allantoin is the way reptiles and birds excrete stuff, and mammals don't. And so this enzyme is actually an additional enzyme which can actually be used to degrade uric acid to make it water-soluble allantoin. The biggest side effects are anaphylaxis, methemoglobinemia, but what's really important is that it can cause significant hemolysis in patients with G6PD deficiency. So if you treat a population where this is a concern, you have to remember to ask that particular question before actually giving to patients. The other thing to remember is that because it's an enzyme, it can get degraded very rapidly at room temperature. So when you actually draw a level, you're supposed to send the uric acid in ice so that you stop the enzymatic action to the lab, and that's how you get a true level of what uric acid. Otherwise, once you draw out of the body, you could actually have a falsely low lab level because the enzyme continues to work. So with that, I've come to the end of this talk, and I'm happy to take any questions. There are a few more slides which I've thrown in for your reference, which in the interest of time we don't have to go through. Any questions? All right, thank you.